Welcome to DentLinks. I'm George Tawil, and it's my pleasure to present you today a patient that consulted for severe edenterism in the maxilla and in the posterior part of the mandible, and on whom we did reconstructive surgery in the maxilla and a more conservative approach in the mandible for a severely deficient case. Patient, a female born in 1959 that has no systemic problems to report, and when she consulted, her chief complaint was an unstable maxillary prosthesis. She was in fact unhappy with her removable partial denture too, but wanted to start with the management of the maxilla. She had had in the past extensive dental treatment. She ended up losing most of her teeth because of poor treatment, poor management, and caries and periodontal lesions. The teeth number 16 and 26 have hopeless prognosis, and in the mandible she has 6 or 7 anterior teeth that can be saved. She has severe vertical bone loss in the mandibular right posterior quadrant, and her demand is fixed restorations. This is how she presented, with a partial denture in the maxilla with 2 teeth remaining, partial denture in the mandible, chronic periodontitis that needed to be attended on the anterior mandible, and quite a severe resorption in the maxilla. The mandible, 1 posterior tooth, the second molar could be saved, the first molar in fact, and the anterior teeth can be saved. She still had enough periodontal support, and this can be treated and managed, and the teeth can be saved. She has an important vertical dimension collapse. She has an anteroposterior discrepancy of the jaws that is in the range of about 8 millimeters. She has a limited interarch space, which may be a problem in the construction of a fixed hybrid implant-supported restoration. You look at the CT scan done in that time. Nowadays would have used a cone beam CT. She has a severe resorption in the anterior part of the maxilla, with about 7 to 8 millimeters of bone left, as you can see here and see here. The posterior part on the left side, practically no bone left, which will necessitate, in case of reconstruction, sinus lifting. On the right side, about 6 to 7 millimeters of bone. Also, for an extensive restoration, we probably need to consider here also sinus lifting. So the treatment planning consisted of placing 8 implants in the maxilla, short implants in the anterior part, and longer implants with the sinus lifting in the posterior part. The teeth, one of them had to be extracted. We probably consider keeping the other one temporarily to hold the prosthesis in place. So the treatment planning consisted of extraction of tooth number 26, bilateral sinus lifting and placement of 8 implants in the maxilla, then temporary maxillary partial denture holding on the parrot and the remaining molar, then extraction of the tooth number 16, the maxillary right, first molar, abutment connection, and a fixed maxillary hybrid implant-supported prosthesis. When this is done, then we will need to consider the mandible. The posterior right and left mandible needed implants, where it is important to note that on the mandibular right side, she has a very severe resorption limited amount of bone left coronal to the inferior alveolar nerve. So this is the situation in the maxilla. We used the lateral window reposition technique for sinus floor elevation. The bone window was prepared using sonic surgery, piezo surgery. The window is removed, the sinus membrane elevated, and the implants are placed. Then on the side number 15, the ridge was narrow, so it needs to be augmented. We use guided bone regeneration for that, along with sinus floor elevation. Once the subsinus cavity is filled with, in that particular case, an organic bovine bone, the window is repositioned. Same technique was done on the maxillary left side, and implants placed simultaneously with sinus elevation. This is the situation after implant placement. In the anterior part, these are Nobel Select, 8 millimeters by 4.3. One of them is a Primark implant, 10 millimeters, and the other implants are Select implants, Nobel Biocare. So we waited 6 months for the implants to integrate, and then, as planned, tooth number 16 was extracted, abutment connection was done in the maxilla, and then once the healing was completed, a temporary fixed prosthesis was constructed to test aesthetics and function, and the patient was happy with the aesthetics. The prosthesis was transformed into a final hybrid implant-supported restoration, restoring function and aesthetics. In those situations where there is a discrepancy between the maxilla and the mandible, there is a need to find space for teeth, the resin or ceramic that holds the teeth in place in the metal-based infrastructure. In that particular case, vertical dimension was augmented within physiological spaces, of course, and the patient could gain again function and aesthetics. And you can see here the restoration completed in the maxilla. Anteroposterior discrepancy could be handled properly using that kind of emergence profile of the prosthesis. The overlap was correct anteriorly. The position of the teeth as to the lip at rest was very good, which restored completely the aesthetics in that case. The primary concern of the patient, along with function, but she was extremely concerned with aesthetics. So this is her smile after the reconstruction of the maxilla. CT scan done post-operatively, showing the elevated sinuses and the implants placed inside. And there was then the concern about the rehabilitation of the mandible. The mandibular left side was severely resorbed. The patient was not very much in favor of doing major reconstructive surgeries, vertical augmentation, and wanted to know whether there is a more conservative approach to the mandible. On the left side, this was not an issue. An implant could be placed inside of the first bicuspid and first molar, but on the right side, there was a need to find another solution to the problem. And when you look at the scan, we can tell already that there was a very limited amount of bone coronal to the nerve. On the side of the first bicuspid, this was not a problem. We could place a rather long implant in that case. But further posteriorly, there was practically no bone left. So to be able to place implant, there was absolute need for vertical bone augmentation. The patient didn't want to go through extensive surgery, and we explained all the goods and bad of these surgeries and the possible complications. And so she said, is there another way to do it? So we elected to place implant lateral to the nerve. And as you can see here on this X-ray, the nerve, the inferior alveolar nerve, is located very much to the lingual side, leaving about 6 or 7 millimeters to the external cortical plate of bone. In that particular situation, this is a good indication to place implant lateral to the nerve. This was done. This is the surgery. Now, in order to approach this situation, we have two ways. Either we can do it freehand, which for unexperienced is a little risky, or we can do it using guided surgery. In that particular case, we did it freehand. We felt secure doing this because of the space between the nerve and the external cortical plate, and we thought that we will be able to achieve this result quite predictably without taking any risk on severing the nerve during the procedure. So what are our references here in doing this particular procedure? It is the external cortical plate in the mandible, as you can see here. We expose it. This is the emergence of the mental foramen here, the nerve at the mental foramen. The external cortical plate of bone is our reference. We take it and we move about 3 millimeters from this external cortical plate, and we place our first drilling using the pilot drilling. And once this is done, we use a number 2 twist drill, and we prepare the site with an angulation of 15 degrees towards the maxilla in order to facilitate secondarily the reconstruction with a more or less proper occlusion. And sometimes we end up having a crossbite, but it's not critical. But we tend to, depending on the distance between the implant position and the position of the occlusion on the opposite arch. But you'll see here in that case how it did manage the case prosthetically. So it is important to start by drilling 3 millimeters from this cortical plate and then twist drill, leaning always when drilling on the external cortical plate. Tendency is for the burr to move into spaces, the marrow spaces. So in order to keep our direction and the distance to the inferior alveolar nerve, it is important to lean on the cortical plate while the drilling is done. This is the site finally prepared, and the two, here in that case we use a Brannemark implant. It was in 2014. So we placed a 2 Brannemark implant, 11.5 by 3.75, and 130 millimeter implant in the position of the first bicuspid with an excellent primary stability. So on the opposite side, 2 implants was placed. This is quite a classical way of approaching the situation. One inside of the first bicuspid and one on the side of the first molar. So 2 months later, we had to do the abutment connection. Now, in order to approach this, we are in an area of alveolar mucosa, so we have no attached gingiva. Of course, there is a possibility of doing a free gingival graft, but it's not really very simple because of the lack of depth in the vestibule, so it would not hold very properly in that case. So we elected to do a vestibular deepening, split thickness. We cut the mucosa here and elevated it buccally, leaving a layer of periosteum and connective tissue. Abutments were connected on the implant, and the flap was sutured apically, and the pack was placed in order to hold the tissues apically. This is the healing 10 days later. You can see that the mucosa is there, and we did not gain much of a vestibule because there was no room for that. And this is the emergence of the implant in a zone of mucosa. It's not easy to gain attached gingiva in those cases. You have no vertical height. The bone is practically horizontal, and the area is we are really completely in the vestibule with the mucosa surrounding it and continuous with the mucosa of the cheek. This is the situation post-healing. This is the situation following the integration of the implants. This is the first bicuspid, and posteriorly, you can see from this CBCT taken at that time the position of the implant as to the inferior alveolar nerve. This is the second implant placed in the position of the second molar, and that is the implant placed in the position of the first molar. We still have approximately 1 millimeter, 1 to 1.5 millimeters distance to the inferior alveolar nerve. Situation perfectly healed with absolutely no neurosensitive consequences on the patient. And this is the situation post-restoration. Fixed bridge was placed on the 3 implants. In the position of the first molar, the occlusion was edge to edge. It was not very much possible to have a regular occlusion on that particular case, normal occlusion. On the opposite side, the situation was, the occlusion was correct. As far as the alveolar mucosa, you can see that there is a zone of mucosa in the vestibule here. So there's this zone of mucosa could cause damage to the bone because it's not stable, and in those situations, as described in the literature, maybe one of the reasons to have marginal bone loss. The bone in that case is very dense, and we did not see bone loss occurring over the past 3 years in that particular situation. Hygiene was correct. It was the patient has the possibility to accede to the area and have a proper oral hygiene. This is the situation in 2013, and this is the situation now. The patient is functioning very properly, and has no problem as far as the as function. As you can see here in the maxilla, we had some recession over these 3 implants, so we recommended the placement of subepithelial connective tissue graft, and so far the patient is resistant to have the surgery. He's not complaining about the aesthetics, and the function remains good. This is the panoramic X-ray taken a few weeks ago, and as you can see, the implants are perfectly integrated with practically no marginal bone loss, maybe just a little bit here, but altogether the function is perfect. 5 years post rehabilitation of the maxilla, and about 3 years post rehabilitation.